Good morning, and welcome to the Arizona Advisory Council on Indian Healthcare's presentation on social determinants and pre-existing conditions affecting the risk of increased COVID severity amongst tribal populations in Arizona. This publication was made possible by a SAMHSA grant number listed at the bottom of the presentation. The views expressed in these materials do not necessarily reflect the official policies or contractual requirements of the Arizona Healthcare Cost Containment System, or ACCESS, or the Department of Health and Human Services, nor does mention of trade names, commercial practices, or organizations imply endorsement by the U.S. government. Now, the Arizona Advisory Council worked with the State Medicaid Agency, or ACCESS, to receive a set of claims that had been submitted to the State Medicaid Agency for American Indian and Alaska Native individuals who are enrolled in the Medicaid program called the American Indian Health Program, or AIHP. Each of these healthcare claims in this data set were submitted between 2020, when the pandemic first began, and June of 2022. And each healthcare claim in this diagnosis field had a COVID-19 diagnosis listed as the primary diagnosis on the claim. This claim release of the data set included 45,910 American Indian and Alaska Native individuals, and no protective health information was included in the data set. So when we received this information from ACCESS, it was actually stripped of any protected health information or personal identifiers. Now, the below data set that we're going to discuss represents the significant findings pertaining to Native populations in Arizona that were found in this data set of healthcare claims. And using this information, we reviewed if there were any social determinant correlations that related to the severity of COVID and whether or not specific medical conditions that were commonly related to COVID severity, if they were having any association of potentially fatal outcomes for our American Indian and Alaska Native individuals in Arizona. Now, if you're curious about why we thought it was important to look at this, specifically to our American Indian and Alaska Native individuals, there were quite a few reasons. First and foremost, our tribal populations in Arizona were hit particularly hard by the pandemic. There were points in time where some of our tribal nations had COVID rates that were higher than Wuhan, China experienced at the height of the pandemic. And that happened early on before vaccines were available and before a lot was actually known about the virus. Additionally, when we were taking a look just at data points throughout the year, there was a very significant decrease in life expectancy amongst our American Indian and Alaska Native populations in Arizona, as compared to not just the rest of Arizona, but the entire country. And additionally, rates of orphanhood were significantly increased. So in Arizona, the decrease in life expectancy was 2.8 years versus 2.1 years nationally. Furthermore, the decrease in life expectancy was not uniform across all demographics. When it came to our American Indian and Alaska Native populations in Arizona, the decrease in life expectancy was actually of 8 years, as opposed to 2.8 years throughout Arizona. And when it came to the rates of orphanhood, American Indian and Alaska Native children, when it came to looking at both the primary and secondary caregivers, per data from the Centers for Disease Control and Prevention, one of every 168 American Indian and Alaska Native children became orphans. This is compared to other demographics, such as one of every 310 Black children, one of every 412 Hispanic children, one of every 612 Asian children, and one of every 753 white children. So the rates of orphanhood were significantly higher. So what did we find when we took a look at these healthcare claims that were submitted for American Indian and Alaskan Native individuals enrolled in our state Medicaid program, specifically AIHP? Well, the first thing we found was the social determinants of health. There were 4 that stood out: smoking and nicotine use, secondhand smoke exposure, lack of exercise, and homelessness. Now, for those of you who are not familiar with what a social determinant of health actually is, those are conditions, and they are conditions that affect where people live, learn, work, and play. They can affect a wide range of health and quality of life risk and outcomes. Some examples of social determinants of health can include illiteracy rates, English as a second language, when you are in an area where most healthcare publications are published in English. They include things like lack of exercise, smoking, secondhand smoke exposure, homelessness, food insecurity. There's a lot of things that are considered social determinants of health. But the four that stood out when we took a look at this data set were the smoking, nicotine use, secondhand smoke, lack of exercise, and homelessness. And what we saw when it came to COVID severity was that there were very significant and elevated risks for our American Indian and Alaskan Native populations there. Now, talking about COVID severity. If we consider something a severe COVID case for the purposes of this discussion, it means that the individual developed bronchitis, an acute respiratory infection, pneumonia, or respiratory failure requiring the use of a ventilator. So that's what we mean when we say a severe COVID case developed. It means the individual not only had COVID, but that one of those additional conditions developed. So when it came to smoking nicotine use, individuals who are American Indian or Alaska Native in this data set, they were 4.58 times more likely to develop pneumonia and 3.5 times more likely to experience respiratory failure. So what does this mean? It means that by cutting smoking and reducing nicotine use or eliminating it, the risk of having a severe COVID outcome decreases. Now, when it came to secondhand smoke, if an individual was not a smoker themselves, but was exposed to secondhand smoke from somebody they lived with, they were 2.65 times more likely to develop pneumonia. They were 3 times more likely to experience respiratory failure. And those are also pretty significant. So what does this mean? It means by not smoking around family members or individuals that you live with, an individual is able to cut the risk of their family member or of their roommates from developing these adverse outcomes if they were to get sick with pneumonia. When it came to lack of exercise, individuals in this data set were 3 times more likely to develop pneumonia. So exercising in somebody's routine can help to increase their resiliency to COVID-19 infection. And homelessness is another social determinant of health we found. Now, when it came to homelessness, we didn't actually see a correlation between homelessness and COVID severity, but we did notice that there was a very significant number of COVID cases amongst American Indian and Alaska Native populations who had a homelessness indicator on their claims. So that definitely was something that jumped out at us when we were reviewing this data set. Now, when it comes to COVID pneumonia and when it comes to pre-existing conditions that an individual might have, what can make COVID worse in American Indian populations in Arizona? And we found that there were a few things that jumped out. First, lack of exercise and secondhand smoke and smoking nicotine use, which we've already discussed. But in addition, diabetes and hypertension jumped out at us. So what does this mean? It means that if an individual has diabetes, by making sure that it's well managed and that their blood sugar levels are very well controlled, that they have a much greater likelihood of having a better COVID outcome. Same with hypertension. So when we took a look at that, somebody with that was 4 times more likely to experience a severe COVID case, and they were 20.47 times more likely to develop pneumonia. So by controlling hypertension, someone can really reduce their risk of developing COVID pneumonia in our American Indian populations in Arizona per this data set. When it came to diabetes, individuals were 14 times more likely to develop pneumonia. So well-controlled diabetes would be something that could help to increase somebody's resiliency. The other thing that really stood out to us was that once an individual in this data set had developed pneumonia, they were 125 times more likely to experience respiratory failure. And once pneumonia develops, the odds of respiratory failure greatly increase. So those are the big things that jumped out at us from looking at this data set. One thing to keep in mind about this data set, though, is that it's really a snapshot in time. We weren't able to see the actual downward progression of individuals through time sequence. So we reviewed every single claim as if they were happening at the same time. That, from an epidemiological perspective, is how the data set was submitted to us when we're taking a look at healthcare claims in this manner when they're stripped to PHI. Because without the PHI, we're not able to take a look at an individual's claim set in sequence. So that was one of the things that we thought we should mention pertaining to this data set. Additionally, our numbers were fairly low on this data set. It only included 45,910 healthcare claims and individuals for this. But we wanted to share those findings with everyone because what we were able to discover is that by controlling diabetes and hypertension, and by not smoking, reducing nicotine use, and through secondhand smoke exposure being reduced, and by exercising, and by having some housing security, the chance of having a severe COVID outcome decrease. Thank you for your time, and we hope that this presentation was helpful.